Welcome everyone to the discussion, and let's see, what kind of question that we might find in the exam in the oncology module. Okay, so our selected questions of today to discuss and the topics that we are going to revise. Will be very relevant to the exam. Okay, we will try to avoid as much as we can so much details in the guidelines. Okay, because the guidelines of oncology all are aware. We have the British Gynecological Society guidelines and Cancer Society guidelines, and we do have the FIGO. Okay, however, those publications are, published to all the specialized people around the world. Okay, it's not only for the purpose of the MRCOG part 2 exam. Okay, so let's see, what the important question from the MRCOG part 2 exam point of view. Okay, so let's start the first question and see how are you going to think and assess, the question. Okay, are we ready? Okay, so we have the question number 1, and the question number 1 says, a 75-year-old presented with an urgent referral. And we all know urgent referral pathways for the cancer. Okay, with a 4 months history of vulval pain. On examination, she had a 4 cm irregular exophatic tumor replacing the clitoris. So when it is replacing the clitoris, this is a midline lesion, right? Extending to within 15 millimeter of the urethra. Enlarged lymph nodes are palpable in the both groins. What is the next most appropriate action? So my friends, when you solve a question, then you have to highlight the most important keywords in this question, and then read carefully what is the leading sentence, and then go to the choices. The choices says 1, to perform a CT scan of the abdomen and pelvis. 1 is to do a simple vulvectomy. 1 is urgent radiotherapy. 1 is vulvectomy and bilateral inguinofemoral lymphadenectomy, and this is based that the patient have the both groins with palpable nodes, or which biopsy of the lesion. So which one you think is the correct one? Okay, so I'm looking to your answer. Okay. Look, my friends, so your answer, it makes sense that if I have a cancer, I need a staging, right? However, in the vulval cancer, the preferred first line imaging is MRI, actually. Okay, so this is one thing. Another thing that the operation that I can do for the removal of the vulva or vulvectomy and bilateral inguinofemoral lymphadenectomy, this can be okay as a method of treatment for a lesion with bilateral palpable lymph nodes. But the leading sentence in the question says, what is next most appropriate action? So please remember, it's not about, in the MRCOG, it's all about words, It's all about words. It's a game of words. So it's not about that I know the answer, I have the knowledge, I know the answer, No, it's not the same. It's what is written there. What is written there is simply next most appropriate step or action. Then I need, in the planning for the management of this case, to know what is the next thing that I will do. Collect a swab, for example, in a patient presented with vaginal itching or a discharge, having a smear test, for example, in the other patient, or abdominal examination in another patient. So this is the next step I'm planning to. in the case, but this is not the final destination, okay? So the next step usually will be something, as I told you, like taking an action for the investigation, okay? Yeah, so here, which investigation that I can do? This is the investigation of taking a biopsy, right? Why taking a biopsy? I'm not going, okay, to start treatment of a cancer or plan for a surgery, okay, without a confirmation of histopathology at least, correct? So what the guideline says, the guideline says that whenever you have a suspected lesion, right, of the vulval cancer, you have to take a biopsy. And the biopsy, what type of biopsy is it? Okay, is it excisional biopsy? So that's why I can't really take a wide local excision. This is against the guideline. I can't just remove the lesion, okay, while I'm investigating. This is a big mass, okay? So it will be incisional and it will be representative, right? Okay, so that's incisional equal punch biopsy, or incisional equal wedge biopsy, or incisional equal representative biopsy? What do you think? I'll tell you. The representative biopsy, okay, it's a biopsy that represented the tumor, means that I will take multiple pieces from the lesion, okay, and I will make sure that I have involved the interface, okay, or the edge of the lesion between the normal tissue and abnormal tissue, okay. So this is called a representative. So the incisional, this is the big category, okay. Incisional biopsy of the vulva is what the big name, okay. And under this big name, it could be a representative incisional biopsy, okay, which is mentioned in the guideline as well, okay. Or it could be a punch biopsy, multiple punch biopsies, okay. Like, for example, they used the multiple punch biopsies in the cervical cancer, for example, okay. Okay, so it could be wedge biopsy, okay. Okay, guys, so the correct answer here is the last option. This is E, okay? So I'm not choosing D. D is wrong. Why? It's wrong because not about the surgery, it's about the question. The question here asking next most. He's not asking about final destination. He's asking about next move, okay? Okay, so please take care. The biopsies, okay, required, the types of the biopsies also is important in the vulval cancer. Okay. In this question number 2, my friends, a 75-year-old woman is seen in the urogynec clinic complaining of a pelvic organ prolapse. Okay, so situation awareness. Of note, there is a history of intermittent steroid cream use. For a sore and itching vulva, on examination, there is a warty lesion on the vulva, which is 1 by 1 cm on the left inferior aspect of the labia majora. So this is lateral lesion. So what would be the most appropriate action? So what do you think, my friends? Is it arranging excision? Okay, so I need you to remember excisional biopsy doesn't have any role in diagnosis. Okay, excisional biopsy is a form of a treatment only. Okay, so excision biopsy of the entire lesion under local, I wouldn't accept this option. Prescribe topical eMRCOG cream on the lesion. Reassure the woman that vulval condyloma are common in the postmenopausal woman and concentrate on the reason for the referral, the pelvic organ prolapse, or refer to dedicated gynecological oncology vulva clinic for an opinion. Try a course of topical steroids and review lesion in 6 months, or vulval punch biopsy. So which one you would choose? Okay, so yeah, we have just mentioned in the previous question that taking biopsy from a suspected cancer case, okay, this is the next step, okay, or the first step in making a diagnosis, correct? Yeah, but unfortunately, again, situation awareness will change the answer. What is the situation awareness? Where are you here? Where are you? You are in the urogynecology clinic, correct? Okay. So you think that taking biopsy will be done in the urogynecology clinic? No, right? So refer to a dedicated vulval, okay, oncology or vulval clinic. Okay, my friends? Very important, my friends, that you understand, again, the situation awareness. It's not about, I know sometimes you find it tricky, sometimes you find that it's overwhelming. Okay. Oh my God, I have studied this guideline, I have done this and that, but I didn't do it in the exam. I'm sorry to say, again, concentration, situation awareness, understanding of the leading sentence in the question. This is what make it different. Okay. Okay. Don't worry, guys, with good training and practice, okay, you will make perfect, inshallah. Okay, so practice is the advice for all of you. Everybody who is planning for January, just practice, practice, practice as much as you can. Okay, of course, having the knowledge is the base where you will stand on. Okay, but having the knowledge is something, and the exam is another thing. Believe me. Okay, practice question as much as you can, and focus and analyze every question. This is how we learn. Okay, or this is how we play the MRCOG game. Okay, so you are about to see a 60-year-old woman on the vulva clinic. Okay, so today I'm in the vulva clinic. She initially presented 2 weeks ago complaining of soreness and irritation of the vulva. On examination, there is a 4.5 cm ulcerated lesion of the left anterior vulva, okay, involving the clitoris. Okay, so this is the midline and it's big, okay. A punch biopsy was taken and the histology reveals a squamous cell carcinoma. Okay. In addition to radical excision of the primary lesion, how will you counsel her regarding lymph node management? So, what do you think? There is a rule for lymph nodes management in the vulval cancer, and this rule is super important, correct? Okay, so the sentinel lymph nodes, my friends, it has a very crucial role, okay, in the vulval cancer, right? Okay, due to many factors. One of them is the anatomy itself of the lymph nodes, the groin lymph nodes, and it's not easy actually to perform a bilateral lymphadenectomy for everyone or remove the lymph nodes and find out if it is involved or not involved, positive or negative. Also, the cosmetic result of the operation is very important, okay, because we don't want to have a big surgery with a big incision unnecessary. Okay, so that's why the role of the sentinel lymph node is very important. But I need you to remember that to have a sentinel, okay, this is a very, 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 okay, important question in the exam. There are criteria to fulfill, okay, and we need to fulfill the criteria before we choose the sentinel, okay. Number one in the criteria, please remember, my friends, that the lesions should be solitary lesion, okay. I can't do a sentinel lymph node in multiple lesions, okay. This is Clear so far? Okay, this is one thing. Another thing is, yeah, it should be less than 4, okay? 4 cm, okay? So here in that question, he was very clearly, okay, mentioning to you guys that the size is 4.5. So since the size is 4.5, you can't really apply, okay, the sentinel lymph node, okay? That's one thing. So again, the unifocal tumor less than 4 in size, okay, patient can be safely managed by removal of the identified sentinel lymph nodes. So I'm sorry, guys, for those who answer the sentinel lymph node is not correct. Okay, and this is some of the rules, okay, of the vulval cancer that we are going to go through it in a minute, okay? But before we do that, let's see what is the best answer for our question here, okay? So the best answer for the question is, I have a midline, okay, a midline lesion. So a midline lesion, and it's big in size, that's require bilateral lymph node removal, okay? So I will do bilateral inguinofemoral lymphadenectomy. Why? Because the lesion in the midline, okay? Midline lesions, my friends, actually drain to both sides, okay? So if I have a cancer here, I'm sorry, guys, excuse me for the horrible drawing, okay? So here, if I have a cancer and this cancer is a midline, okay, or near to the midline within 1 cm, this cancer lymph drainage go both ways, both sides, okay? So it's here and here. This is the anatomy, right? So if I got the cancer, then I will remove the lymph nodes on both sides. Okay, so this is rule number 1 to learn. Okay, once I have central lesion bilateral lymphadenectomy. Okay, this is one rule. Rule number 2, let's speak about this because it's a very important rule. Rule number 2 says, if I have lateral lesion, okay, lateral lesion, and this lateral lesion, okay, on the assessment, okay, of the tumor, like by the MRI or whatever scan I have done, okay, and by the clinical examination, no palpable lymph nodes, and the lymph nodes is not seen, okay, on the imaging. So I have to check, right? Okay, so when I check and I found that the lymph nodes are positive. Okay. Okay, if the lymph nodes are positive. So what shall you do? Lymph nodes positive now, and you wanted to remove the lymph nodes. Now it should be what? Ipsilateral or bilateral? When you remove ipsilateral, okay, because we have lateralized the lesion, okay, on one side, when you remove it ipsilateral, okay, and you found that there is positive nodes, you have to go and remove the other side. Okay, so the frozen section can be helpful in this case. Okay, so okay, so if I have, my friends, again, if I have the rules for lymph node removal in lateralized tumors, ipsilateral groin lymphadenectomy can be performed initially. In unifocal tumor less than 4 cm, remember, and is not seen by scan, okay, can be managed by removal of the identified sentinel lymph nodes, okay? But in cases of positive lymph nodes identified, what shall I do? Other side should be removed or not? This is my question. Look, my dear, okay? The sentinel lymph node is the lymph node specifically that drain, right? This tumor, right? Correct? Correct. Does this mean that all the sentinel lymph nodes should be positive on the histopathology? So if you have positive sentinel lymph node, okay, from one side, you have to remove the other side. You get the point, my dear? A little bit when you read it for the first time or when you study it for the first time, you find that, oh my God, I'm a bit confused, but it's not a confusion here, okay? Simply the rules of the vulval cancer and the lymphadenectomy, okay, we can say it's like a general rules. There are a general rules to manage the lymph nodes in the vulval cancer, okay? The general rules to manage the vulval cancer says, if you have starting with the very, very small lesion, okay? If you have very small lesion, okay? So if you have very small lesion and the staging of this very small lesion is 1A, for example, okay? Do I need to perform a lymphadenectomy? No, I don't need. Okay. So once I have more than 1 millimeter depth of invasion, what shall I do? Okay. So what shall I do? I will assess, okay, before the surgery. Assessing by the surgery, guys, everybody look to the screen. Please confirm that you can see the algorithm of the vulval cancer, okay? Here I'm taking the pathway of the vulval cancer since it's a biopsy proved, okay? And yeah, vulval squamous cell carcinoma, okay? And if I have less than 1 millimeter depth of invasion, that's mean which stage is this? If I have less than 1 millimeter, okay, I have the 1A. So what is the management of this stage? The main management of this stage is very easy and it's wide local excision, right? And it's mentioned again, like radical wide local excision, which means that removal of the lesion with a good size of safety margin, okay, and normal tissue surrounding the lesion. So that's why it's radical, okay? Radical wide local excision. And with documentation, okay, by photos and vulval diagram, the body diagram, okay? So sentinel lymph node biopsy is not required in stage 1A, okay? Happy so far? Some publication, Dr. Isra, used wide local excision, but they mean also wide local excision with the safety, with good safety margin. Some of the publication also used the term radical wide local excision. Both are correct. Okay, so sentinel lymph node is not back again to the algorithm. Sentinel lymph node is not required in that stage. It's a very early stage, and local management or local tumor removal is enough. Okay, good. So how about if I have more than 1 millimeter, okay, and the depth of invasion. So that's mean I am dealing with the further stages, right? Okay. I need to do before going to the surgery or before deciding what type of surgery is needed in this case for the inguinal lymph node assessment, okay, by clinical examination, by imaging, okay, all techniques can be used in this case, okay? So if I have a primary lesion less than, after the assessment, okay, if I have a primary lesion less than 4 cm and no suspicious lesion or notes on the scan, so very important in the question that examination was fine, scan was fine, okay? However, I need, okay, to test the lymph nodes that have the drainage, right? That the drained lymph node. That's very important. So sentinel lymph node biopsy is applied here when the size is less than 4 and no suspicious nodes on scan. Okay, so now after I take the sentinel lymph node biopsy, okay, and this will be taken unilateral if I have a lateralized lesion. If I have a lateral lesion, I will take the sentinel lymph node from one side only, on the same side of lesion, okay? But if I have a midline lesion, okay, what shall I do with the midline lesion? I take bilateral. Midline lesion means one of the midline structure means that it involves the clitoris, for example, it involves the urethra, for example, okay? Or within 1 cm of the midline. So it is managed like a midline lesion. If it is midline, remember, this is the anatomy, okay? Centralized lesion, well drained to both ways. So I have to remove the sentinel lymph node from both sides, okay? The question here, did I speak about any positive lymph nodes yet? Did I say anything about positive lymph nodes? No. Okay. No. Good. Good. Okay. So now we know what to do if the primary lesion is less than 4, right? And no suspicious nodes on a scan, okay? Which is presumed to be relatively early stages, but I can't confirm without testing the lymph nodes. Okay, that's why we do the sentinel lymph nodes. On the other hand, the other arm of the algorithm says primary lesion 4 cm or more, or multifocal disease, or suspicious lymph node on the scan. Okay, so what shall I do on those cases? Big lesion 4 cm or more, multifocal disease with 2 to 3 lesions, for example, or presence of suspicious lymph node on scan, what I will do in this case? In this case, I have to perform inguinal lymphadenectomy, correct? In cases of lateral lesion, I will take ipsilateral lymphadenectomy, okay? I will remove the lymph nodes on the same side. If it is centralized lesion or within 1 cm of the center of the midline, what I will do? Here I will do unilateral lymphadenectomy or bilateral lymphadenectomy. I will do a bilateral lymphadenectomy. Well done, well done, okay? That's because it is centralized. Okay, so how if on the frozen section, you know, the frozen section is very widely used, okay? Or on the assessment of the lymph nodes, okay? You found that the ipsilateral lymph node that it was removed came positive. If the ipsilateral lymph node is positive, what you will do then? You will go and remove the other side. You will remove bilateral now. Okay? Guys, is it clear so far? Okay? So removal of the lymph nodes, okay, it's according to the lesion, okay? Okay, centralized lesion, you need bilateral lymphadenectomy, okay? The lesion is lateral, okay? And 4 cm or more, or multifocal disease, then ipsilateral removal. If the ipsilateral nodes removed found to be positive, go back and take the other one, bilateral. Okay, rule of the sentinel lymph node, remember, it's in a small size tumor, okay? Small size tumor, less than 4, and it is not suspicious on scan or not suspicious by the clinical examination. So we take sentinel lymph node biopsy in this case. Understood, my friends? Okay. So guys, if you need to receive your questions, please write it down. Okay, so the question of Dr. Ahlam. Okay, Dr. Ahlam is asking a question about is it in another operation or in the same operation? This is will depend on the policy of the place. If the place are doing the frozen section technique, so they are testing the lymph nodes on the same time, okay, it can be in the same operation. If they are not using the frozen section, okay, so it will be with another operation. That's it. Okay. The FIGO, yes, Dr. Ahmed, you're so much in love with the FIGO. We're following the guidelines. Okay, there is a difference between the guideline and the FIGO. So what we will do is we simply, okay, apply the guideline. Okay, so there is a point of the difference between both of them. However, the guideline is updated, so I'm following the guideline. And the RCOG is following the same guideline. The RCOG resources, also the e-learning resources of the RCOG using the same. Dr. Isra, my dear, we don't assume things, okay? According to the algorithm, if they mention more than 4 cm, then lymphadenectomy should be done, okay? If the lesion is lateralized, you take ipsilateral. If the lesion is centralized or within 1 cm of the midline, you take bilateral, okay? That's it, easy. Okay? Okay, so I hope that it's clear so far. 65-year-old was referred with soreness of the vulva. On examination, there is a raised irregular lesion with an erosive appearance measuring 1 cm in diameter. What would be the next step? What would you do next? Obtain a representative incisional biopsy, perform a wide local excision, refer to a cancer center, or request a groin ultrasound scan, or request MRI. So, okay, so we refer to Vulval clinic. We have referred the patient from the Vulval clinic, sorry, to the Vulval clinic to obtain the biopsy or for the further assessment, right? Okay, I can't remove a patient, any patient with any type of a cancer to an oncology center without any proof, okay, that this patient is having a cancer. Okay? If you have a suspicious lesion, you take a biopsy, simply. Right? 1 second, my dear. This will be a very good chance, 1 second, to revise. The first algorithm, okay? So is the screen visible to you guys? Please confirm you can see the screen anymore. Because it seems like I clicked by mistake on something. Okay, is it visible now? Okay, good, very good. Okay, guys. Okay, so let's see. Yeah, it will be a good chance, okay, to review some facts. Right? Okay, are we ready? So let's take it from the very early beginning. Okay, the story in the vulval cancer and the vulval lesion started with itching, right? So a patient present with vulval itching. Okay, this can be anything, correct? Okay, what shall I do if a patient presented with a vulval itching? Yeah, examination, that's good. It's a, yeah, good. Okay, obtain the history and examination. Yes, well done. Okay, so if you think by the history and examination that this patient have chronic dermatosis, okay, like lichen sclerosis, for example, or lichen planus, okay, what you will do? What you will have to do in this case? Okay, do I go for a biopsy at the first instant? Can I do that? Can I just go for a biopsy? Because the patient have what I think it's a lichen sclerosis? No, I don't go for a biopsy if I think that the patient have lichen sclerosis. I treat first. Okay? I treat according to the clinical examination. Right? Yeah. Yeah. Okay. Good. Very, very good. Okay. So when to consider biopsy for a patient with chronic vulval itching? We consider biopsy, my friends, in a chronic vulval itching on a patient on this situation. Our patient have suspicious, okay, cancer. So if you think that you have a suspicious cancer, okay, then you go for a biopsy, right, to confirm what do you have, right? Okay. Or this patient does not respond to treatment. So you are treating this patient, or the GP is treating this patient as a lichen sclerosis case, for example. Okay? Right. Okay. So most of the patient will just respond well to the medication, right? Okay. Patient is not responding well. What does this mean? This means that I either have something more than just a skin dermatosis, maybe, or I maybe have, okay, another problem, correct? Or this is progressed into cancer, even if the chances of cancer are not very high, okay, but I might have, okay? So failed treatment or suspicious lesion will lead to, okay, one thing, that is the biopsy, okay? Okay, once I have confirmation by the histopathology that this is a cancer, what I will do next? I'm going to do what is called an oncology MDT referral. Okay, this case is not going to be managed by a single doctor. Okay, this case will be managed by a team of doctors, and the team of doctors are not general gynecologists anymore. The team of doctors are, okay, yeah, oncologist, okay, or gyne-oncologist people. Yes, I love you so much, my friends. So this is the story, right? When a woman presented with confirm or refer. I can't refer to cancer center without anything to say that you have a cancer. Okay, guys, I'll tell you something. Okay, I'll tell you something that is can help you so much. Okay, what is this thing? I tell you that we need to revise the basics. Okay, we need to clear concepts before we try to solve the questions, especially in tricky situation or tricky subject, right? So this algorithm, can you see it? Okay, this is from your guideline. This is from the vulval cancer guideline. This is the first algorithm in this guideline. Vulval lesion, okay, plus or minus symptoms of pain, bleeding, or irritation. Okay, if the patient presented with low suspicion of cancer, let's start this one first. Okay, so what you will do, you will look to the examination. If it is clinically benign, reassure. Okay, okay. If it is clinically VIN, either the usual type or the differentiated type, okay, bunch or wedge biopsy, including lesion, margin, plus taking photo. Taking photo for documentation in the vulval lesions are very important because this will help follow up, okay? And plus or minus diagram indicating the biopsy site. Don't perform excision biopsy without histology. Okay, so anybody who suggests wide local excision as initial or first management for a lesion, okay, is wrong. Okay, so my friends, you have to make sure, okay, that you have a histopathology first before you remove any lesion. Okay, as this is may rule out option of sentinel lymph node of cancer diagnosed. Okay, so this is if you have even clinically VIN. So you take a bunch or wedge biopsy. The third arm of the low suspicion of malignancy in this algorithm. Guys, can you see? I'm sorry. Don't want to disturb you. Can you see the screen now? Yes, okay. That's good. I think some of your friends, they don't see the screen, maybe internet connection or something. So clinically, okay, like lichen sclerosis, for example, you will take clinical photos for later comparison, treat with nightly ultra high potent topical steroids, no improvement after 2 weeks or treated adequately prior to referral. So if there is no improvement, okay, after 2 weeks, bunch or wedge biopsy, including lesion, margin photo, plus or minus diagram indicating biopsy site. Okay, so can you see here? This is for a low suspicion of malignancy. This is when you have a patient presented with symptoms of pain, bleeding, or irritation. Okay, and you are not suspecting cancer. This is maybe lichen sclerosis or VIN or anything else, okay? So this is for low suspicion of cancer. Or how about high suspicion of cancer? High suspicion of cancer is what you have said now, okay, in a minute, that doctor, this is clearly cancer. Okay, even by the description, okay, you think that this is high suspicion of a cancer, you have to take a biopsy. Look how the algorithm go. There is one arrow here to show you which biopsy. Which biopsy? Taking photo, again, plus or minus diagram indicating biopsy site, document lesion size, and the distance from the midline structure. Okay? Then look what comes next. Ta-ta-ta! Refer to gynecology team. Okay? Don't perform excision biopsy or wait for the biopsy result. You're going to initiate the referral. The biopsy result will go, okay, automatically to the team. Clear? So far? Okay, so look, everybody would be happy, satisfied, okay, when they just follow the evidence of the guideline, right? Okay, let's continue. Few questions before the first break today. Okay. So our friend here, what is the answer of this question? I hope that you can see the question now on the screen. Well done. Okay, so you've noticed here they used a representative, correct? Yes, they used the term representative. Okay? Okay, representative biopsy. Okay, a representative biopsy. Incisional biopsy, right? So everybody now is familiar with the change in the description of the biopsy type. It doesn't matter, okay? A representative is like incisional biopsy, is like punch biopsy. They, they use this in question on the vulval cancer. So 70-year-old woman presented with 3.5 cm by 4.5 cm raised irregular fungating mass on the left labia extending to the clitoris. A representative biopsy of this lesion has confirmed a moderately differentiated squamous cell cancer of the vulva with a depth of invasion of 8 millimeter. What is the most optimal management plan for this woman? What do you think? So here they are asking about the final distration. Okay. Okay, I'll answer this question and then come to the next one. Okay. So guys, everybody have choose what? Which choice? B, radical wide local excision with bilateral groin lymphadenectomy. Okay. Okay, good. Yeah. So simply, okay, the mass on the left labia, but it extends to the midline. It extends to the clitoris. So simply bilateral. Well done. Okay. Well done, my friends. I think that you are doing very well now. Okay. Answering this tricky question. Okay. So I have seen a question in the chat. Okay, some of our friends has shared this question from the group. Okay, from our group. Okay, it's like is show me. Okay, doctor, I have evidence against you guys. Okay, so let's read the question, my friends, and see. Okay, Dr. Ala, don't worry at all. Okay, I'm reading the question and I'm explaining the answer to you. So we said, or we agreed together, that we are bounded with options in this MRCOG game, right? So I have a 65-year-old referred to the two-week wait. So she's referred to the 2-week wait general gynecology clinic. Okay, so already they have initiated the urgent referral pathway because her general practitioner observed an irregular vulval ulcer, with raised edges while he was performing a rectal examination for suspected hemorrhoids. What will you do next? Okay, and he give you 5 options. One option is magnetic resonance imaging, which is not, okay, the one. Take an excisional biopsy. So no excisional biopsy at all. Okay, however, 16% of the candidate have choose excisional biopsy. This is really worrying. Okay, or urgent referral to cancer center. Okay, so Dr. Rabah just said, and she showed us on the algorithm that I have to take a biopsy first, then I will refer to the cancer center, not even waiting the biopsy result. But let's see the other options. Urgent referral to gynecology consultant, no rule. Wide local excision, again, excision, no rule. So I have 4 wrong answers, and one comes as a second priority. So which one to choose, Dr. Ala? So guys, you got it. The best available answer is to refer to cancer center. I don't have the option of the biopsy, correct? So if it is incisional biopsy, this will be 100% correct. Okay? Okay. Okay. Thank you very much. I'm happy that it's clear for you guys now. Okay, let's have our break now, my dear friends. Allow me to have a break in 10 minutes, and I'm coming back to you, inshallah. And we're going to start another collection of questions to discuss some tricky points from the cancer management. Okay, thank you. So my dear friends, we do have here another case of a 30-year-old presented to colposcopy clinic having a cervical smear showing low-grade dyskaryosis and positive for high-risk HPV infection. No relevant past medical history. She had a family history of her maternal aunt and grandmother both dying from cervical cancer. She smokes, 10 cigarettes per day and had recently smokes 10 cigarettes per day and had recently broken up with her partner. Her children are aged 13, 6, and 2. BMI is 36. She had regular period and no postcoital bleeding and no vaginal discharge. She is on Depo-Provera for contraception. What is the most appropriate advice regarding her management? So what do you think, my friends? Have a cervical biopsy or have a colposcopy and biopsy or any abnormality revealed, or have a colposcopy and no abnormality are seen, have a repeat cervical smear, or have a hysterectomy if her family is complete, or have an excisional biopsy using LIDS. So everybody have choose B. Okay. So obviously this question was written, okay, as the patient have a cervical smear and she had HPV positive and low grade dyskaryosis. Even if it is written on the old style, okay, however, the management is the same. So we don't mind the management, okay? So the best option for her would be to have a colposcopy and biopsy for any abnormality revealed, correct? That's easy. Thank you very much. So in the next question, we see a 25-year-old woman have multiple biopsies of her cervix at the colposcopy clinic due to high-grade dyskaryosis. Her histology shows CIN3 with areas of microinvasion. Okay? What is the most appropriate advice regarding her management? So for CIN3 and areas of microinvasion, what you will do? Well done. Well done. Everybody have choose to have an excisional biopsy using LITs or other technique, right? It can be, yeah, it can be LITs or even conization, but this is the most important thing that we assess, correct, the type of the lesion. If we have obtained a clear margin and it's found to be 1A, what you will do? If the case is 1A, 1, okay, so the management is local excision. Local excision is enough for early stage for micro-invasive disease, correct? Yeah. Okay. So the rule of the trachelectomy comes from actually, okay, the patient who wants to preserve her fertility from the 1AB, correct? Yeah. It's a fertility sparing option. However, if the patient doesn't want to preserve her fertility, or the patient presented already very old age, what you will do? Okay, so will be a total abdominal hysterectomy. Okay, 1 second, my friends. If I give you choices between hysterectomy, okay, type A, or hysterectomy type B, or hysterectomy type C, which one you will choose? Yes, excellent, well done. This is according to the update, okay, the recent advances in the cervical cancer. It will be the type A for the case of 1A1. For the 1AB, should be what? Yeah, I'm sorry, I said 1A. Okay, B, I'm sorry. Yes, I have noted this. I'm sorry. it seems like I need my coffee. Yes, I mean 1A2. I'm sorry, 1A2. This is different from 1B. Yes. Quickly revise the difference, okay, between the types of the hysterectomy. So simple extrafacial hysterectomy, this is for the type 1, okay, hysterectomy, or type A. And this is suitable for 1A1, okay? And for 1A1 with lymphovascular invasion, however, this is uncommon, okay, or this is something that we don't see very commonly, to be honest, okay? But some cases, if there is lymphovascular invasion with 1A1, this is will go for type B, the modified radical hysterectomy, okay? 1A2, once we are in 1A2, okay, the surgery will be the modified radical as well, okay? The type C, or the radical hysterectomy, not the modified radical, start from 1B1. Okay, my friends? So from 1B1, I'm starting the radical hysterectomy. From 1A1, if the patient does not require fertility according to her risk, let's say the patient is old age, okay, and she doesn't want the, the local treatment, or she have any other problem that necessitate hysterectomy, so we can perform simple extrafacial hysterectomy. For 1A1 with lymphovascular invasion, which is the minority of cases, but still there is a place for that, we go for type B. If it is 1B1, we go for type C. Okay, so as you can see, my friends, okay, the cervical cancer management is like a bit aggressive. Okay, that's because of the sensitivity of the type of this cancer, and because of the high spread of it. Correct? Okay. For the fertility sparing option, please remember that fertility sparing option apply for 1A1, 1A2, and 1B1. Correct? As long as the lesion is less than 2 cm, we are okay to preserve the fertility, either by the local conization, okay, with or without lymphadenectomy, or with trachelectomy with lymphadenectomy, according to the stage as well, right? Yeah, hi. Okay. So guys, can you see my new presentation here? Can you see the screen now? Okay, that's good. That's good. Okay, so my friends, okay, we would like to have a quick revision for the cervical cancer, okay, and we'll try to explain every small point, okay, that is required in your exam. Yesterday, actually, I had one session, okay, for the cervical cancer, and they requested for my candidates that they just make homework, okay, where um, they have a summary, okay, of the cervical cancer, right, as in one table to just write by stage, okay, the cervical cancer stage 1, 1A, 1A, 1, 1A2, okay, 1B, and so on. But you know what? Nobody have sent the homework. So, okay, Dr. Nada, she is the one who saves, you guys, and she had made the table. Okay. Okay. So that's great. Okay. So guys, here we'll have a look at the cervical cancer. For the cervical cancer 1A1, okay, the treatment for the fertility sparing is conization. However, I would like to add that for the patient who doesn't require fertility, hysterectomy is the management of a choice, especially in elderly patient or patient with higher risk of other gynecological condition or cervical cancer in general. What type of management or the surgery that we will advise, will be the for 1A1 without lymphovascular invasion, this will be the simple extravascular or type A hysterectomy. Okay. For fertility sparing, conization could be enough. Okay. And can be done by the cold knife. Okay. And it has one advantage over the large loop excision or the lids. Why? Because the margins will be clear. Okay. And if the patient found to have involvement of the lymph nodes or lymphovascular invasion even, okay, so the sentinel lymph nodes or lymphadenectomy will be advised. Stage 1A2, okay, remember again, stage 1A2 means that I will advise type B, right, hysterectomy. Okay, okay. So for the radical hysterectomy, remember we always do it with bilateral salpingo-oophorectomy, okay, plus or minus bilateral oophorectomy with bilateral pelvic lymphadenectomy, correct? Okay. If the patient require fertility with 1A2, according to the update of the figure, okay, it says that we can do it with conization with lymphadenectomy, right? Or we can do it standardized is the trachelectomy with a lymphadenectomy, correct? Okay, so for the 1B1, what do you think that option is? From 1B1, I'm starting to add the hysterectomy. Which type of hysterectomy? Is it modified radical or radical? If it is a hysterectomy, then it will be a radical. Yes, well done. Good, good, very good. Okay. From 1B2, what is a very important notice from 1B2 in the treatment, my friends? . The notice from 1B2 is that both surgery and radiotherapy, okay, have the same efficacy. Okay, so it will be according to the NDT and the woman wishes, right? Okay. Once we have 1B3, so what do you think about? Yeah, okay, so it will be either we go for a surgery, right? Followed by radio, which will actually increase the morbidity and mortality rates for this treatment, or we go for the CCRT, right? So the CCRT, my dear friends, or the combined chemo radio, okay, this is the preferred treatment from the 1B3 and ongo, correct? For the advanced stage, okay, this is will be according to the situation or according to the type of the cancer, okay? So they might add external beam radiation plus the CCRT, okay? So the patient will have a brachytherapy, a form of a brachytherapy, correct? And this is will be, yeah, this is will be along with the CCRT, okay? So the important, my dear friends, the important thing that you need to remember in the adjuvant treatment after surgery for the cervical cancer, okay, that we are giving the adjuvant chemoradiotherapy, okay, but this is can actually increase the risk of the morbidity and mortality. However, in high-risk patient, high-risk factor like presence of positive or pelvic para-aortic lymph nodes, we had to do this, okay? Or for parametrial spread, for example, or for the cases of with positive surgical margin, or cases with patient with high-risk factor, okay? So this is will be considered for adjuvant treatment after surgery, even if the surgery for a relatively early stages. Okay? So here are some important notes collected for the important notes in the cervical management. Okay. And if I ask you, my friends, what is the best scan for staging in the cervical cancer? Especially when you have a tumor more than 1 cm. Yeah, MRI is the best method of radiological assessment. Yeah, excellent. Okay, will I go for PET scan for staging? PET scan can be useful for detection of nodal metastasis greater than 1 cm, okay? And in this case, it will be more accurate than the CT and MRI, okay? This is in areas, please be careful. This is in areas with high prevalence of tuberculosis and inflammation, especially HIV endemic areas. Large lymph nodes are not necessarily metastatic, okay? So it has a role in the staging, but otherwise it's very useful in the recurrence. You can use the fine needle aspiration or biopsy to exclude metastasis, lymph node metastasis, okay? And nowadays, the FIGO, okay, is no longer mandates any biochemical investigation or investigation procedure. Like, for example, if a patient uh, had cervical cancer in the old days, we used to say we will go for examination under anesthesia, we will perform a sigmoidoscopy, a colonoscopy, a cystoscopy, correct? But nowadays, they only say that we would do this, okay, for a patient who have symptoms, okay, or a complication. right? Like, for example, in patient with frank-invasive carcinoma, a chest X-ray and assessment of hydronephrosis, okay, with renal ultrasound, CT, and MRI should be done, okay? However, the patient who have a problem, okay, like hematuria, will be assessed by, for example, a cystoscope. But if the patient does not have other symptoms, okay, you're only staging now the cervical cancer. Okay? A quick revision, my dear friends, and this will be the end of our session today. This is a quick revision to the algorithm of managing cervical cancer in pregnancy. So, my friends, in the pregnancy, you remember the important rule that any pregnant woman who have a cancer, right, or high risk of having a cancer should be investigated normally, like the cervical screening program says that normal screening or routine screening would be deferred until after delivery. But if the patient have symptoms or the patient have any suspicion of a cancer, or due to her having higher risk before and she become pregnant, this patient should not be just left untreated because she is pregnant. Okay, correct? So what we will do for this patient, proper investigation using the colposcopy and the biopsy if needed, okay, will be offered. Once you have a confirmed diagnosis of cervical cancer in pregnancy, remember, okay, that again, pregnancy is not a contraindication for treatment, correct? The patient will receive treatment, but we will keep the patient autonomy, okay, in the top of our, on the top of priority of the management. So here they started the algorithm of management from the 1A2. Why do you think they have started from the 1A2? That's because 1A1 is already managed by conization, so there is no problem, and conization can be done during pregnancy, provided that it's done in a place with facilities, okay, to manage the complication and hemorrhage and with good expertise, correct? So here I have 1A2 and 1B1. What shall I do for these cases? You remember that those cases, 1A1 and 1B2, 1B1, sorry, they have a tumor size, okay, with maximum 2 cm, correct? So let's see, what can I do for them? In this TUG article, okay, or in this part of the algorithm, they have used the 22 weeks gestational age, okay, as a cutoff of action or a turning point in the management. So if you have relatively early pregnancy below the 22 weeks of gestation, then you can make an assessment of the pelvic lymph nodes. So the pelvic lymph node dissection can be done below the 22 weeks, right, of pregnancy. Yes, it can be done. It's found to be positive. That will change your decision or will make a very big difference in whatever you are going to tell the woman, right? So pelvic lymph nodes dissection comes as positive. What you will advise in this case? I'm so sorry, I'm advising termination of pregnancy. Correct? Okay. So if the pelvic lymph node is negative, so I have a better prognosis. So I can offer this lady either treatment or to delay the treatment until after delivery. What type of treatment I can offer to 1A2 or 1B1? The type of treatment that can be offered here can be the local treatment, okay, like trachelectomy. Yes, correct? Okay, so trachelectomy can be offered here for this patient, okay, and here it's not radical trachelectomy, it's a simple trachelectomy, of course, okay, or the option to delay the treatment until after delivery. Right, my friends? Is it clear so far? Okay. In 1B2, 1B2, this is gestational age. Again, sorry, we have forgot one. I'm sorry. So if the gestational age more than 22 weeks, okay, there's no rule to do a pelvic lymph node assessment. So you are afraid here, you have a doubt whether the pelvic lymph nodes are negative or positive, what to do. We are already past the 22 weeks in the pregnancy. So the baby can have a chances. Okay, so what to do? Here, to either offer treatment in the form of a neoadjuvant chemotherapy, or you delay the treatment until after delivery, and the choice for the mother, of course. Okay, so is neoadjuvant chemotherapy safe in pregnancy, my friends? Yes, it is. Okay, but contraindicated only in the first trimester, and it can be given in the second and third trimester with, of course, the supportive medications like antiemetic, for example, and stop it before the delivery 3 weeks to give a chance for the mother and fetus bone marrow to recover. Okay? So now this is for 1A2 or 1B1. Now I have 1B2. In 1B2, the same rule apply. They will give gestational age 22 weeks as a cut point, okay? A turning point in the management. Less than 22 weeks of gestation, what you will do? What you will advise? You will advise pelvic lymph node dissection, okay? So the pelvic lymph node dissection came as positive. What you will do in this case? Once it's positive, the risk of the woman life, okay, due to the advanced cancer is high. So termination of pregnancy, I'm sorry. Okay. If it is negative, and here I might correct this for you guys, the arrow should go this way. If it is negative, so again, give the option of either neoadjuvant chemotherapy or delay treatment until after delivery. Okay. Otherwise, if the lady, my friends, is having gestational age 23 weeks, for example, and stage 1B2, what you will do? (23) and stage 1B2, what you will do? If it is already past the 22 weeks, okay, no rule for the pelvic lymph node dissection. So you will offer either the neoadjuvant chemotherapy or delay treatment until delivery, and this will be the woman a choice. Okay. So yeah, here is the choice: neoadjuvant chemotherapy or delay until after delivery. Yes, well done. Guys, once we are in 1B3, okay, so actually the rule of the lymph node assessment is not well established. Okay, it's already 1B3. You know what is the size of lesion in 1B3? Do you have any idea? Okay, more than 4. Yes, well done. Well done, Dr. Sidra. Okay, well done, Dr. Wen and Dr. Nada as well. Okay, so no rule for the pelvic lymph node assessment or dissection. So you either advise neoadjuvant chemotherapy or termination in the early pregnancy, or neoadjuvant chemotherapy and delay until after delivery, okay, if it is advanced disease more than 22 weeks. Okay, dears? Is it clear so far? Okay, so I'm so happy, my dear friends, to be with you today. And I'm so sorry for the delay in starting and the interruption in between. It's really a busy day. Thank you very much. Okay, Dr. Sana, I'm going to share the recording. Of course, I'm very glad to have you. Okay, I think that we have covered some valid point, okay, in the vulval cancer and in the cervical. Next time, we're going to cover ovarian and endometrial, okay, with some tips for the update in both guidelines. Okay, guys, so I'll see you in the next session. Thank you very much. I'm very happy to have you today and looking for more sessions with you. Thank you. I love you. Bye-bye.